Alright, let's get into the next prostate disorder, prostate cancer. This is the most common cancer and the second most common cause of cancer deaths in males. Risk factors include age older than 50 and if the person is of African descent. Prostate cancer usually develops from gland cells and is called adenocarcinoma. Other prostate cancer are rare but can include small cell carcinomas, neuroendocrine tumors, transitional cell carcinomas, and sarcomas. Prostatic adenocarcinoma is most commonly found in the peripheral zone, which generally involves the posterior lobe. This is super important, because it's actually pretty far from the urethra. So what happens is, those tumors can get pretty big before they cause problems with urination. Prostate cancer may not show symptoms in early stages, but more advanced cancer can lead to symptoms such as difficulty urinating, bleeding and pain with urination, and ejaculation. If the cancer becomes metastatic, it most commonly spreads via the vertebral venous plexus, also called Batson plexus, to the axial skeleton, resulting in hip or lower back pain. If the pain gets worse at night and isn't relieved by rest or position change, it may indicate metastasis rather than benign cause. Metastatic lesions are typically osteoblastic or sclerotic and not lytic. Diagnosis starts with digital rectal examination, and prostate feel like firm, gritty, irregularly hard lump. Also, prostate cancer can increase level of certain tumor markers, such as prostatic acid phosphatase or PAP and prostate-specific antigen or PSA. Since PSA elevation is not specific, what helps determine the risk of cancer is calculating the free to total PSA ratio. PSA can circulate in the serum in two ways, either on its own or free PSA or bound to other proteins. A low free to total PSA ratio indicates a higher risk of cancer and may require a prostate biopsy. The biopsy can be done using different methods, such as through a probe placed in the rectum through the skin of the perineum between the scrotum and rectum, and may use an MRI scan or transrectal ultrasound or TRUS. Small pieces of tissue are removed and examined under the microscope. In the microscope, what we would classically see are small glands that infiltrate the normal prostatic tissue. The characteristic finding is that the nuclei of the tumor cells have dark nucleoli. Based on the architecture of the tumor cells, the tumor can be scored using the Gleason grading system. The Gleason score is a number assigned to prostate cancer based on how much the cells in the cancerous tissue look like normal prostate tissue. The score is calculated by grading the tissue on a scale of 1 to 5 and then adding the grades of the two most common areas of the cancer. The highest possible score is 10. Cancers with a score of 6 or less are considered low grade and rare, likely to grow and spread slowly. Cancers with a score of 8 to 10 are considered high grade and are likely to grow and spread quickly. Cancers with a score of 7 can be either low or high grade, depending on whether the score is 3 plus 4 equals 7 or 4 plus 3 equals 7. In 2014, the International Society of Urological Pathology introduced the grade group system, which uses 5 grades to simplify the prostate cancer grading system. Sometimes prostate cells look abnormal but not quite cancerous. In prostatic intraepithelial neoplasia or PIN, there are changes in how the prostate cells look, but the abnormal cells don't look like they are grown into other parts of the prostate, like cancer cells would. In low-grade PIN, the patterns of prostate cells appear almost normal. In high-grade PIN, the patterns of cells look more abnormal. Many men develop low-grade PIN, but it's not related to prostate cancer risk. If low-grade PIN is found, no further action is necessary. If high-grade PIN is found, there is greater risk of prostate cancer. Doctors often monitor men with high-grade PIN carefully and may advise another biopsy. In atypical small acinar proliferation or SAAP, also called glandular atypia or atypical glandular proliferation, also reported as suspicious for cancer. All of those terms mean that the cells look like they might be cancer when seen with the microscope, but there are too few of them to be sure. If one of those terms is used, there is a high chance that there is also cancer in the prostate, which is why many doctors recommend repeating the biopsy within a few months. And finally, proliferative inflammatory atrophy or PIA. In PIA, the prostate cells look smaller than normal, and there are signs of inflammation in the area. PIA is not cancer, but may sometimes lead to high-grade PIN or to prostate cancer directly. After a prostate cancer diagnosis, doctor determines the stage of the cancer to determine the best treatment. The most widely used system for prostate cancer staging is TNM system. This system is based on 5 key pieces of information: the extent of the primary tumor, this is T category, whether the cancer has spread to nearby lymph nodes, this is N category, and whether the cancer has spread to other parts of the body, this is M category, and the PSA level at the time of diagnosis, and the grade group, which measures the likelihood of the cancer to grow and spread quickly. There are 2 types of T categories for prostate cancer: clinical T and pathologic T. The clinical T is your doctor's best estimate of the extent of your disease, based on physical exams, prostate biopsy, and imaging tests. The pathologic T is determined after all of your prostate has been examined in the lab and is likely to be more accurate than the clinical T. For more information about TNM, please click the link in the description below. Now, regarding metastatic disease, radionuclide bone scanning can be also done to look for bone lesions. If they are present, serum alkaline phosphatase will be elevated as well, and this can be a useful screening tool for recurrent bone metastasis. In terms of treatment, then the tumor is confirmed to the prostate and hasn't metastasized, surgical excision of the prostate, also known as prostatectomy, is done along with radiotherapy and hormonal therapy. Now, the most commonly tested medication used in hormonal therapy are leprolide and flutamide. Leprolide is gonadotropin-releasing hormone, or GRH, analog that's then administered in continuous fusion, resulting in downregulation of GRH receptors in the pituitary, which then reduce LH and FSH secretion, both of which promote androgen secretion and the growth of prostate cancer cells. And flutamide is an androgen receptor antagonist. So, both leprolide and flutamide deprive cancer cells of androgen stimulation. Sometimes, older individuals with low-stage non-metastatic prostate cancer might decide to undergo active surveillance instead, since prostatectomy can cause certain complications, like damaging the prostatic plexus, resulting in erectile dysfunction. If the tumor has metastasized, however, treatment options include radiation therapy, chemotherapy, and hormonal therapy.